Yes, Ruchira.
Yes.
So this is just I initially took it as an approach to anemia, but the majority of the talk is about iron deficiency anemia itself. So we will stop whenever you want me to stop. There are a lot of cases that we can go through. A little bit of theory about iron deficiency anemia in the beginning. So what do we actually call iron anemia? Anemia is not a number by itself. It's actually a definition says where your hemoglobin level is too low to meet your cellular oxygen demands. And if you're looking at a statistical diagnosis, then we say 2 standard deviations below the mean for age, gender, race, and developmental status of the child. So there will be different cutoffs for different ages that are present, and everyone needs to have their nomograms ready to be able to see what is the actual cutoff for that particular age, gender as well. The WHO actually gives you a number just because it wants to make it universalized for people. So it says that infants who are from 6 months to almost 5 years of age, we will call it anemia wherever the hemoglobin is less than 11. But for 5 to 12 years, this number is 11.5. For menstruating women, it becomes 12. And then for pregnant women in the second trimester, it is less than 11 as per the WHO criteria as well. For men, the number is 13 grams per deciliter is the cutoff for them. So this is just the average cutoff, but because we have neonates and all, we will need to look at our own cutoffs present. Why do we need to do this? And what do we need to look at when we are looking at anemia is you want to not know just the Hb, but you also want to know the other things around it as well. You have to look at the TLC and the DLC to make sure that it is anemia, or is it a bigger paradigm of like an aplastic anemia or something else that is. And also look at the platelets as well. So the complete hemogram becomes very important for us. And not just looking at the hemogram, looking at the Hb, you have to look at the other indices as well. So you look at the total red blood cell count, you look at the MCV, you look at the red cell distribution width, because that's a very important marker when you're looking at iron deficiency anemia. And in our country where we need to differentiate iron deficiency anemia from thalassemia traits, then an RDW really helps us out. We also look at the hematocrit, which is generally a mechanized or a machinized, it's just a formula that's used. So your Hb into 3 would be your hematocrit. But in cases of dengue syndromes, when you're saying this, then your hematocrit actually goes much ahead than what is the more than the expected hematocrit. Also look at the MCH and the MCHC. We'll just see what these values are for. As I said, look at the white blood cell count and the platelet count as well. Look at the differential count as well, because you may have a normal white cell count, but your differentials will tell you that this child is neutropenic, or there may be some blasts present or abnormal cells, monocytosis present as well. Whenever you're thinking of anemia, always ask for a reticulocyte count, because that tells you how your bone marrow is functioning. A good reticulocyte count in the presence of a low hemoglobin tells you that the marrow is trying to recover and so is working hard. And also ask for a peripheral smear examination. No anemia is complete without having a peripheral smear examination. So that becomes very, very important for us in our diagnosis and how we diagnose it. So Hb and the RBC count, everyone can understand that that's the hemoglobin content of the red blood cell and the number of red blood cells that you find. Whenever you have anemia, you are expecting that your red blood cell count as a compensatory mechanism might also may decrease if it's an acute blood loss, but if it is a prolonged deficiency, then your RBC count can sometimes actually increase as well, because your marrow is trying to produce more cells, although it's an ineffective production. The MCV reflects the cell volume, whether it is a big cell or a small cell. When we look at, when we think about anemia, we always talk about microcytic or macrocytic anemia, and that is where the MCV helps us. In most cases of iron deficiency anemia, we know that we'll be dealing with a microcytic. The cells become smaller in size because they're not getting enough nutrition. MCH is the mean concentration of hemoglobin, which reflects the hemoglobin content of each red cell. And the concentration is by the MCHC, which means that your cell, whether hyperchromic or hypochromic. Now with iron deficiency anemia, we know we get a hypochromic anemia where the cell content, the concentration of Hb in each cell is also low. And like I said, you have different parameters for different age groups. When you're looking at neonates, then you look at your hemoglobin. About 37 to 40 weeks of gestation will be as high as 16.8. But then once the child, if it's a premature child, then you may get lower hemoglobins as well. And similarly, your hematocrit and your reticulocyte count may be normal, but will be different from the normal average that we see. What are the different factors that affect our baseline hemoglobin? There are a number of factors which are age, gender, race, sexual maturation of the patient. So younger children might have different hemoglobins. Altitude at which you're staying, a higher altitude, you tend to have a higher hemoglobin. And also hereditary causes may also be affected. We all know about the physiological anemia of infants. And the reason why I put it there is that we generally say that iron deficiency anemia will not happen before 6 months of age. So nutritional anemia will never happen before 6 months of age. You have to see whether this is a physiological anemia or is there another cause for this anemia if your anemia is presenting before 6 months. In preterm babies, however, this nadir may actually come a little earlier. So we are generally expecting it to come at around 2 months, but it may be coming at around 6 weeks or even 4 weeks for premature infants and also for mothers who are iron deficient themselves. So start expecting your physiological anemia to happen between 6 to 8 weeks of age. We know all about physiological anemia of infancy. So generally we say that from 16.8 they will drop their hemoglobin, they will reach a nadir of about 11 at around 8 to 12 weeks, and then they will start picking up themselves. But as I said, preterms might actually reach this earlier. All this is because there's a combination of decreased red blood cell mass, there's iatrogenic losses, there's a shorter lifespan of the neonatal RBCs present, inadequate erythropoietin production, and a very rapid body growth, which means that your requirements are much higher in these patients as well. Whenever you're looking at anemia, we generally tend to describe anemia based on the cell volume. So we describe it as smaller cells, which becomes microcytic, normal size cells, which are normocytic, and higher or bigger size cells, which are macrocytic. And based on your RBC number, you can always tell whether this, what is the reason for it. As I said, if there is an inadequate production happening, number actually you see a higher red blood cell RBC number as compared to your Hp volume, your Hp content. Whereas if it is low or normal, we start thinking of Ideopathogenesis anemia or anemia of chronic inflammation, or sometimes even sideroblastic anemia. If you have a normocytic anemia, if the size of the cells is normal, then you're thinking of hemolytic anemias or bone marrow disorders present. And if you have macrocytic anemia, the commonest diagnosis we face is B12 with folic acid deficiency. You can also find macrocytic anemia present with liver disease, with hypothyroidism, and also post chemotherapy in our patients. So whenever you have macrocytosis, try and correct for iron and folate, and then we start looking at other causes. Then you can also classify anemia based on the mechanism. So is there a decreased production or is there an increased destruction? And increased destruction is more likely to happen whenever you have red cell enzyme deficiencies or hemolytic anemias present, or if there is immune hemolysis happening. Whereas decreased production happens with nutritional anemias, with congenital bone marrow failure syndromes, with B12 deficiencies, or with hypothyroidism. So this becomes a quick estimate, what are you dealing with? And as I said, you generally should not get a nutritional anemia before 6 months of age. There is hemorrhaging present when all pediatricians and neonatologists in this group would have dealt with. This could be antepartum, this could be intrapartum, this could even be the neonatal period. Most of the times this is generally blood loss that is happening, or it could be sepsis that could be the reason for this. So to deal into hemorrhagic anemia, I will switch on to the next part. So there is a rule of thumb. So how do you determine what is the lower limit of normal? So we have an 11 plus 1 rule. It's whatever is your age in years, that plus 11 will give you the lower limit of normal for your hemoglobin concentration. And for your CV, the rule is 70 plus the year. So 70 plus the age in years will be your lower limit of normal for your MCV. So just as an example, a 2-year-old with a hemoglobin of 11.3 and an MCV of 73 is normal, because if you follow the 11 plus 1 or the 70 plus rule based on this, for a 2-year-old, this still comes to within normal limits. However, if this was a 7-year-old child, then this is abnormal. This child is anemic and is microcytic. So you know that you can just quickly look at the age of the child and just do a rough estimate and then take it on from there. Also, you look at, as I said, the reticulocyte count. Now, the reticulocyte count is a marker of the immature cells that are being produced, and they kind of flow into the blood. That tells you how well your bone marrow is functioning. So those reticulocyte counts, we measure them and we decide that. Now, sometimes when you have anemia, your reticulocyte count may be low, but when you look at it as correcting it from the actual hemoglobin, then we say it's a corrected reticulocyte count, and that is what you need to look at when you're looking at anemia. So just looking at absolute reticulocyte count doesn't help. You have to look at the reticulocyte, at the corrected reticulocyte count, or what is also called the reticulocyte production index, which is your reticulocyte count into 0.5 into so that is something that we need to look out. So if you have that's more than 3, then you know that this is hemolytic anemias, and if you have an RPI less than 2, then you're looking at ineffective or decreased production in these patients. There are some other diagnostic tests based on what you're suspecting. You may also want to order them, like a blood group and RH when you're thinking of this, or a test for maternal blood losses or fetal-maternal hemorrhages. If you're thinking of pulmonary hemorrhage, you might want to look at a chest X-ray, a bone marrow aspiration, looking at torch titers if you're thinking of sepsis, or a DIC panel, or maybe asking for an ultrasound examination or other tests depending on what your suspicion may be. But these are a few tests that you would need to do it. As an algorithm looking at anemia, we think of first the Hb concentration. So you define that if the child has anemia. You look at your reticulocyte count based on low and normal. Then you generally ask for a Coombs test. The Coombs test tell you whether there is autoimmune hemolysis happening. If this is positive, then this is definitely an immune hemolytic anemia. In the neonatal period, it's most commonly an ABO incompatibility present. If it is negative, then you look at your MCV. If your MCV is low, you know that this could be a thalassemia syndrome, especially an alpha thalassemia syndrome, or it could be a chronic intrauterine loss, so low birth weight baby with a chronic intrauterine loss happening. But if your MCV is high or normal, then you look at the peripheral smear and you look at the other parameters. So you have, you can think of infections. If you have your toxic granules present there, you can look at blood loss. Or you can look at, if your peripheral smear shows you abnormal cells, then that can tell you exactly what you are dealing with. So you can get spherocytes, you can get schistocytes, you can get other abnormal cells present. So all this can be estimated by your peripheral smear itself. So whenever you're thinking of anemia, please ask for a peripheral smear itself. I will move on to case presentations, and with each case we'll do a bit of discussion as well. So this is a 1.5-month-old child, so 1.5 months only, so about 6 weeks. Complaint of birth weight was 2.5 kgs, but there's no history of neonatal jaundice. There's a history of fever in the mother for the last few weeks of pregnancy. And when we looked at the child, there was pallor present. There was a spleen that was 4 centimeters. The liver was 8 centimeters. So the hepatosplenomegaly. TLC was 11,000 and platelets were 1.8 lakhs. The Hbe electrophoresis was 25%. Now I just pushed that Hbe electrophoresis over there because with neonates, we know that they will have HbF present. So we're looking at, whenever you're thinking of thalassemia, look at it at 6 months down the line. Don't look at it for 2 months. Think of it only around 6 months of age, unless there's a history. And then we ask for the peripheral smear. I think the peripheral smear is diagnostic for all of us. Malaria, yes. So the history of the mother, and this tells you that this is malaria present, and the child was anemic because of this itself. Then you have a second patient who's about 18 months now, presents with pallor and fatigue. He's been a picky eater. He's also been noticed to have been eating dirt and also kind of the play paint of the walls. Otherwise, very, very hemodynamically stable, doesn't have hepatosplenomegaly, but again has microcytic hypothermic anemia because the MCV is low at 55 and the platelets here are high, 520,000. Normally, your platelet count is 1.5 lakhs. Your reticulocyte count 2.1, but this is an absolute reticulocyte count. So I want to see what the total corrected reticulocyte count is. But the total iron binding capacity, which had been done by the pediatrician, was high and the ferritin was low. Also, when you take a detailed history, he's predominantly milk fed.
Iron deficiency.
Iron deficiency anemia. You know it. You have the history suggesting iron deficiency anemia and you have the lab parameters to tell us this. What would be your differentials in this case? So the first differential that comes into us is alpha and beta thalassemia in these cases. It could be major, it could be minor, it could be an intermediate also that is presenting right now. We also look at sideroblastic anemia and keep that in our minds. Because he's been eating the paint of the walls, you think about lead poisoning, although in modern houses, we don't see that much of lead poisoning. The paints are lead free now. But if this was an old home, then I would still keep that on my mind. And then always there's anemia of chronic disorder. When you look at the peripheral smear, this is classical for us. On the left-hand side, you can see the normal smear. So that's what a normal red blood cell count looks like. And when you look at the count cells over here, if you can compare, you can see that they are smaller in size. They have a big central area of pale, this thing, which is the central pallor present. And so that makes them microcytic. And you can see that there are different cells, different shapes of the cells present. Some of them look like target cells because they're giving you an area that target cells. But what is called is anisopoikilocytosis is the cells are of different shapes. Also, if you look at the platelet count with the small blue dots that you see over here, you can see that they're actually increased as compared to what you see on the left-hand side. So you know that there is a compensatory thrombocytosis happening in these patients. Just as an aside, thrombocytosis in pediatrics is 80% of the time is compensatory. It's secondary thrombocytosis. So we never worry about thrombocytosis. And the most common cause for this is iron deficiency anemia. So if you think thrombocytosis, you look at the MCV, MCH, and MCHC, and you rule out anemia first before anything else. Okay. What is the ideopathogenesis of iron deficiency anemia? First of all, oral intake, which is the most common intake. It's an inadequate intake, and usually we have children who are predominantly milk fed. In India, we really, really stress on milk and milk feed. So it's not just iron, he's also deficient in B12 and folate in these patients. What we normally started saying is that you have to start weaning from 6 months of age, and then you have to make sure that he gets other foods also apart from milk. We generally want milk maybe once or twice a day, that's it, not more than that. You also worry about absorption in these patients, so decreased acidity. If there are some inhibitors like they're having iron on a full meal or things like that, or there may be malabsorption states as well. Ongoing GI losses. Commonly in our children, we see worm infestation. So when we're thinking of prevention of anemia, we have to look at deworming our children as well. Milk protein allergies, peptic ulcers or meckles or any other polyps can also be present, which can lead to chronic loss. And in adolescents, we'll worry about menstrual losses or even pulmonary hemosiderosis if you have ruled out the other causes as well. What is the treatment for iron deficiency anemia? And the reason why I moved to treatment first rather than prevention is that in India, almost 70 to 90% of the children are anemic. So prevention actually hasn't really so far, as in whenever you see a patient, you will generally find that they are anemic itself. So we have to start looking at treatment first and then counsel to make sure that this doesn't recur again. So the prevention happens is like a secondary prevention that is happening. So one is decrease the milk intake for these patients. A lot of us pediatricians tell us that cow's milk is for calves, not for humans. Human milk, once it stops production, then you should also be looking at stopping in milk intake in these patients or decreasing it as much as possible. We asked you to promote iron-rich foods, but we all know that iron-rich foods may not be enough treating anemia itself. Yes, it's a very good supplement, but that just by giving iron-rich foods is not going to work. You need to control and evaluate blood loss. So we always deworm all our children who come in with nutritional anemia, also thinking that they will have some kind of worm infestation happening. And you look for any other blood loss if you find that you're not being able to correct it normally. So you may need to do scans, Meckel scans and other things. Unless they are hemodynamically unstable, there is no rule for blood transfusions if you've made sure that this is nutritional anemia. So even if they come in with a hemoglobin of 6, I won't say 3, but if they come with a hemoglobin of 6, then we can build it up over a few weeks, knowing that they're hemodynamically stable. If they're hemodynamically unstable, you think they're in CHF, then you need to transfuse them urgently. And generally, the formula that we use is 4 into the weight of the child into the deficit of hemoglobin that you're looking at. And you want to raise it up to generally about 10 at least. After that, you can build up more. So if you have a child who has a hemoglobin of 6 and his weight is 10 kg, so you're looking at 40 into 10, 4 into 10 is 3 into the deficit is 6. So you're looking at about 240 ml to be transfused. The other way you will look at it is you can transfuse maximum up to 20 ml per kg. Generally, we say it is 10 to 15 ml per kg, but if you have severe anemia, then we want to use a lower dose but give it as 2 or 3 aliquots, but that's still 20 ml per kg is what you can transfuse these patients. Generally, transfusion recommendations are over 3 to 4 hours. We generally don't want the blood to be standing there for more than 3 to 4 hours because then it gets infected with bacteria. So try and complete the infusion. Even if it's 2 units, it has to be finished within 4 hours. So it goes 2 units, 1 unit every 2 hours. But you don't need transfusions. What we generally will prescribe will be oral iron supplementation. And the dose that we're looking at is about 3 to 6 milligrams of elemental iron per day. We will talk about this. There are a lot of iron preparations present, and to make a choice about what iron supplement you want to use, it's whatever you would like to comfortable with and what you think has fewer side effects, as long as the child gets anywhere between 3 to 6 milligrams per kg of the elemental iron per day. There were trials to see whether we could go on a higher dose, but we found that it just increases the side effects. It really doesn't cause an incremental increase in your Hb. So you can start with 3 if you're finding the 3 is inadequate, move to 4 or 5, but don't exceed 6 milligrams per kg per day. With iron supplementation, remember that we generally want to give it on an empty stomach because food acts as it decreases your absorption. So it should be on an empty stomach. Usually should be given with vitamin C. We avoid teas, we avoid milk with our products. So either you give it at bedtime with at least 2 hours gap after meals, or you give it first thing in the morning and then wait for an hour before you feed the child. So that's generally the situation we look at. The side effects, we know that iron preparations can cause both diarrhea as well as constipation. So if you're getting diarrhea, then you advise them to give it closer to a meal so that the iron absorption is a little slower. But if you're getting constipation, then we don't stop the medication. We just ask them to take laxatives with it and add vitamin C so that the absorption gets better with it. IV iron therapy usually is not recommended in pediatrics. Till now, there are a few studies coming in to say that yes, it does have a role and we should be thinking of it. Most of the cases when we're looking at iron, IV iron is whenever we're thinking of either a malabsorption state, or we're thinking of end-stage kidney disease, or we're thinking of iron refractory iron deficiency anemia, where you know that the iron levels are low, but whenever you're giving the oral supplementation, the child doesn't actually respond to it. So these are the few indications for IV iron therapy. We will discuss this also as well. How do you assess response to define if it's refractory? Most of the times you measure your reticulocyte count. So you've done a reticulocyte count and you know that your reticulocyte count should increase within 4 to 6 days. 1 week later, you call the child and you should see that the reticulocyte count is increasing with the iron supplementation now. Your hemoglobin should increase by 1 gram per deciliter per week generally. Initially, it's faster, then it kind of slows down. So it takes us at least about 4 to 6 months to kind of completely treat the patient, because what you're doing is you're not just treating the anemia, you're also replenishing the stores of the patient. So once your CBC normalizes, you need to still continue your iron therapy for another 3 months to replete all the iron stores of the body. So remember that it's not just your HB coming up to 12 or 13 or whatever is the normal for age. You need to also factor in for the replenishment of the stores as well. If you find that it's refractory to oral iron therapy, then the commonest cause is non-compliance. As you can see, it's non-compliance, non-compliance, non-compliance. Unless you've actually made very sure, documented it, seen the blister packs, everything to make sure that yes, they have actually complied with the treatment. Then you think about malabsorption, or you think about an iron refractory iron deficiency anemia, or you think that you have some other diagnosis. It's not just nutritional anemia. But in most cases, it is just refractory iron therapy. And that is where IV iron therapy is now, it's impossible to do 6 months of iron therapy every day. There will be lapses happening. The children will be fussy about it, will not want to take therapy. The mothers will forget it. So there will be lots of it. So that's where the role of IV iron therapy is now coming in as well. Then a word about prevention for iron deficiency anemia. What is the recommendations? So how do we prevent iron deficiency? The WHO recommends that for children 6 months to about 2 years of age, the recommendation is that you should be giving them between 10 to 12.5 milligrams of oral iron for 100 consecutive days per year, which means that for 3 months, they should be getting this iron supplementation. Then for 2 to 5 years, it is 30 milligrams per day, again for 3 consecutive months. And for 5 years to 12 years, it increases to 60 milligrams per day for 3 consecutive months per year. There are trials going on in India, especially for adolescent females, where we're finding that giving it every day is very, very difficult. So what they're doing is they're giving it twice a week. And this is part of your school programs or your Anganwadi programs, where the ASHA worker goes in on a Monday and a Thursday, goes and gives the dose of iron, 60 milligrams of elemental iron, to the adolescent females and the young adults as part of the nutritional anemia prevention program that is happening. 30 to 60 milligrams of elemental iron is almost equivalent to 300 milligrams of ferrous sulfate, about 180 milligrams of ferrous fumarate, or 500 milligrams of ferrous gluconate. There are different preparations available, and most of the preparations will actually tell you how much elemental iron is there. Otherwise, this is a rough calculation that you can use. So if you have 300 milligrams of ferrous sulfate, it's about 60 milligrams present. Iron preparations. In India itself, there's about a 360 crore industry that is actually there looking at iron preparations, and you will find the whole gamut of iron preparations over there. Plain iron, iron with folic acid B12, iron with multiple vitamins in it, sustained release capsules, entry-coated capsules. There is just anything you can think of, it is there as well. The few things that we have generally is, we all know that iron is absorbed from the duodenum. That's the first part of the duodenum, is where the iron absorption is happening from. So enteric coated tablets or sustained release tablets, actually they used to say that you will decrease the gastric irritation that happens with it, but it will delay your absorption. The drug, the medication will pass through the duodenum by that time, and the coating will not have gone off. So it may not be very effective at all. So we're not recommending entry coated tablets at all. We're not recommending that you give a sustained release preparation. What we generally recommend, we all know that ferrous sulfate generally has the best bioavailability, so that's best absorbed. So if you can get a ferrous sulfate tablet, which is what is the Anganwadi's workers are giving to people, that generally works the best. Again, as I said, there's a huge range of products available. You have ferrous fumarate, you have ferrous gluconate, you have ferrous ascorbate, colloidal iron, you have carbonyl iron present anywhere. We generally say, look at what the elemental iron is being provided, and you match your dose with that based on it. So there are a whole range of preparations. I've tried to give a few of them over there with the elemental iron preparation that is available in it, and you can choose whichever one you want to give with that. Again, most of them have some supplements with it. So folic acid and B12 is fine, but apart from that, a vitamin C product being added to it or multiple amino acids being added to it generally does not have any impact on the absorption or the availability. We've generally found that ferrous sulfate or ferrous fumarate are the two that are best absorbed, and the others kind of follow through. Your carbonyl, your colloidal iron generally gives you a lesser gastric irritation present, but children get used to it very quickly. I very seldom come across children who tell me that they're really having problems. Most of them generally get diarrhea or constipation post their iron supplementation, plus their coating of their tongue and their teeth become black. That's it. What is the role of IV iron therapy? So as we said if it's IBD patients or if it's end-stage renal disease where you know the absorption maybe it's a malabsorption stage present, or if you have iron refractory iron deficiency, so where there is a functional defect that is present, then you want to give iron therapy. Standardized dosing, there is no standardized way to give it. What we generally do is people tend to give it either twice a week or 3 times a week. We have formulated we have a formula to kind of estimate what is the total iron dose required for it. Again, different formulas have different people have different formulas for it. Whatever you want to choose between the two, you can use. But remember that you also have to compensate for the iron stores. So both the formulas in the Ganzoni formula, you have to compensate for iron stores. And the way they do it is they say that children who are less than 35 kgs, you look at iron stores of 15 milligrams per kg. For children who are more than 35 kgs, you just take a standard of 500 milligrams as replenishment doses as compensation for the iron stores. But if you're looking at the other more pediatric formula, then they're looking at 3.4 is the conversion of hemoglobin to iron, but 1.5 times so that you can look at the iron stores being compensated and fulfilled in that. Most of the IV iron preparations you give as 1 milligram per ml dilutions, and you give it over an hour or so with normal saline as well. And again, there are a lot of preparations available. Initially, people were using iron dextran, but they found it had a lot of anaphylactic reactions of pain at the IV site. So we moved over to either iron sucrose or ferric carboxymaltose preparations, which generally don't require a test dose present, and but you still have to monitor them. You just can't leave it like that. And total doses recommended. We generally use the formula, so we are not looking at 1000 or 1500 milligrams. We look at the deficit and we calculate it and give it maybe twice a week till you are compensated for the deficit. But it's not just iron deficiency anemia. So whenever you're thinking of iron deficiency anemia, you have to keep your differentials in mind. And one of the biggest differentials that we come across is thalassemia. So I will just use another 10 minutes to talk about thalassemia as well. Now, the commonest presentation of thalassemia, you also know, comes around 5 to 7 months. This child presents with progressive pallor and lethargy because he's becoming pale. Again, at this age, they're exclusively breastfed. You may notice a prominence of forehead. You may notice mild icterus, but most of these children have hepatomegaly. Some of them may actually have a splenomegaly as well, because there's extramedullary hematopoiesis happening in these patients. The bone marrow is going into overdrive, try to compensate, but still having an ineffective production. So there's extramedullary hematopoiesis happening in these patients. The anemia is generally microstatic hypothermic anemia, and you notice that the RDW is 17 in these patients. Now, why is the RDW important is, we'll go back later. But when you look at the cells are generally a little more uniform in shape as compared to what we had seen for the iron deficiency anemia slide. You can still find a few target cells because you can still have thalassemia and iron deficiency anemia coexisting as well. So before you plan a blood transfusion, please ask for an Hbe electrophoresis. Usually, as I said, you ask for the Hbe electrophoresis after 6 months of age, because by that time your HbF levels should come down to less than 1%. So if you have a high HbF on your HbLC, you know that you're definitely dealing with a thalassemia syndrome in these patients. And you also look at your HbA2 levels when you're looking at HbLC. So thalassemia can be either a decreased production of your alpha or beta globulins, or it could be an imbalance between the two. It leads to anemia, it leads to bone marrow expansion, it leads to extramedullary hematopoiesis, and it also leads to increased intestinal absorption of iron. So these children become high in iron. They're not iron deficient, they're actually having iron overload happening in these patients. So giving them extra iron doesn't help them. Again, a recommendation is that when we're looking at dietary restrictions, we really don't impose dietary restrictions on children. What we say is you don't give an iron supplement to these children. You just ask them to eat a normal, well-balanced diet, and they will get their iron from it. Thalassemia, alpha thalassemia, and beta thalassemia. And even in beta thalassemias, you have a whole spectrum of thalassemias. So your Hbe electrophoresis might be saying that this child has thalassemia major, but you may find that this may be very different from somebody who needs an occasional blood transfusion to somebody who needs blood transfusions every 15 to 20 days itself, and will be needing lifelong transfusions as well. So there is a whole spectrum of this. Those that need occasional transfusions, we call them as thalassemia intermedia. But we know that when there is a growth spurt happening, they will start needing transfusions there. So an intermedia will eventually transform into a thal major. But if you have a thal trait, which is what most parents of thalassemic patients are, then they do not have any problems except that they have a slightly low Hp level. So if you're looking at the thalassemia major, you know that the commonest age is between 6 to 24, 6 months to 22 years of age. If they present late, if they haven't come to you initially, then you find the full hemolytic faces, that the thalassemic faces with prominent mandibular and maxillary bones, prominent foreheads, a greenish tinge, and hepatosplenomegaly. But if they've been picked up earlier, they may not actually have these faces as well, and they will be needing recurrent blood transfusions. Otherwise, there will be failure to thrive that is present. So that's the typical thalassemic faces that you can see. We often come across massive hepatosplenomegaly, and they need kind of regular blood transfusions present. The intermediate, as I said, they present at a later age, but you will see that they will need transfusions, and sometimes they haven't been transfused well, so you do get the thalassemic faces present. And these children tend to have leg ulcers and thrombotic complications, and because there is an increased intestinal iron absorption, so they will be iron overloaded, so their ferritins will be high in these patients. But if you have a thalassemia intermedia, a thalassemia trait, this is a heterozygous carrier. So there are different terms being used. You can call them thalassemia minors, you can call them thalassemia traits, or you can also call them heterozygous carriers for beta thalassemia. They're all indicating the same thing itself. They have low or slightly subnormal hemoglobin levels. They have microstatic hypochromic anemia present. But what the differentiation is that you look at their HbA2 levels should generally be more than 3.5 to 4%. And your peripheral smear will show you the erythrocyte morphological changes, but not erythroblastoid changes. So if you look at a thalassemia trait, that is where your red cell distribution width becomes important, because there your red cell distribution width is generally around 14, which is the RDW. Standard deviation and coefficient of variation. So we generally look at the coefficient of variation over there. And you also calculate the Menzer index, which is your MCV divided by the red blood cell volume in these patients. So if your Menzer index is less than 13, then you know that this is a thalassemia trait. However, if your Menzer index is n times more than 13, then you know that there is iron deficiency coexisting. So Menzer index is a very good differentiating factor. And then there are other factors as well. There's a King's index, there's a Srivastav index and all that, which you can use to differentiate between a thal trait and an iron deficiency anemia. Red cell distribution width, we generally say that if it is less than 15, it's a thal trait. If it is more than 15, there is always going to be iron deficiency anemia there. And you may have people who will have both coexisting. So a thal trait may have iron deficiency anemia, and then that time if you're looking at their red cell distribution width, you will treat them with for iron deficiency till their RDW comes down to normal, and then less than 15, and then you stop the iron supplementation for them at that stage. So that's what we've discussed the HPLC. That's how it looks like. And when you look at the HbA2, we can see that this is 3.5 over here, which tells you that this is a phthalate. This HPLC is also very important because for your counseling, there's no reason. This is not a disease. It's just a presence that you're a beta thalassemia. What you need to be wary of is when you're getting married. We don't want two traits to marry because we don't want thalassemic children to be born. So that's also a lot of reassurance and just a good counseling pre to marriage. As us hematologists, we always say कि अपनी thalassemia HPLC report मिला लो बस. That is what is important before you get married. So that's what we keep telling the patients. There is a condition called Hbe Heterozygous, again, which may or may not need blood transfusion. So it becomes a differential for your iron deficiency anemia patients. And here you notice that your Hba concentration is more than 5%, so 31%. This is generally a heterozygous condition if it's about the range of 30 to 40%. But if this became high at 77, then this would be an Hbe homozygous. Generally, we have Bengalis who are Hbe, either heterozygous or homozygous conditions present. There's also a condition called Hbe Beta Thalassaemia, and in this case, you will find both your HbF levels high and you will find your HbA2 concentrations high. So that's how you diagnose an Hbe Beta Thalassaemia, and these children will behave like thalassemia makers. So they will need the transfusions. They're the ones that we advocate bone marrow transplants for them. So again, something to keep as a differential for your iron deficiency anemia. So if you're looking at suspecting iron deficiency anemia, you do your workup, you look at your MCV, MCHC, you look at your ferritin levels, and then you think about doing an HPLC for all our patients. If your ferritin levels are low, then it's definitely an iron deficiency anemia. But if your ferritin levels are more than 12 nanograms per milliliters, then you should get an Hpe electrophoresis done. That is needed for this. I can actually stop over here, but there are a few cases if you want to discuss, or we can stop as well.
No, I think we should go over the cases, Ruchira.
Right. So 4-year-old male noticed that he was appearing yellow and he had dark colored urine. There's also a history of yellowish discoloration of the eye, which the father also had. So the father also had a history of jaundice, and when you look at the CBC report for this 4-year-old, you again found hemoglobin low. You had a low hematocrit, you had a very low red blood cell count. So there was some hemolysis, and the reticulocyte count was very high. So this told you that this was hemolysis happening for these patients. The dark colored urine is again an indicator there is hemolysis. The family history of yellowish discoloration tells me that if I ask for a peripheral smear, I will be looking at hereditary spherocytosis. So whenever you're looking at these kind of patients, again, differentials for microhypoanemia, you look at family history of these, you look at whether this is a new onset anemia or whether this has been going on previously, and look at jaundice. So when you're looking at inherited conditions, we're looking at hereditary spherocytosis. We're also looking at G6PD deficiency or a pyruvate kinase deficiency, and we're thinking about thalassemia in our patients. If you think that this is an acquired condition, then your autoimmune conditions or immune conditions kind of take over. And here this could be infection driven, which is generally a cold antibody driven condition. So you have cold antibodies being formed, or you could have an autoimmune condition like an SLE seen more in adolescent children as well. There are sometimes non-immune causes as well, and IVIG is a non-immune cause. So if the child has received IVIG, you may actually find their DCT coming positive. So that tells you that this is a iron deficiency. This is a non-immune anemia as well. Our differentials, we said hereditary spherocytosis was the first one. We're also thinking of thalassemia because hemolysis can present. We're also looking at enzyme deficiency. A G6PD can present with acute loss and acute hemolysis happening, and that could present with a similar picture that the child develops jaundice. The family history may or may not be there in those patients, and we look at infection-induced causes as well. And this is what your parents may the cells are very, very kind of similar size, spherocytes present, and you can make a diagnosis here. Now, when you're suspecting HS, the recommended test before a few years was that you ask for an osmotic fragility test. And that is how you would pick up an hemolytic hereditary spherocytosis. Nowadays, the trend is to ask for a flow-based report, which is called an eosin malamide assay, EMA. It's a flow-based report, so it's more sensitive in that way, and it is more easily reproducible. And OF is generally very, very observer dependent. So the test of choice has now shifted to asking for an eosin malamide assay for a hereditary spherocytosis. And the treatment is generally just symptomatic care in severe splenectomies in these patients. Next patient is a 15-year-old boy who presents with a history of fever, sudden onset breathlessness, and a rapidly progressing jaundice. There's also a history of death in the family, another sibling who died due to a similar episode present. B pictures, severe pallor, tachypnic with desaturations, mild splenomegaly present. Hemoglobin was just 5 grams. The TLC was high, but you also had a lot of nucleated RBCs present. Platelets were normal. Bilirubin was 10. They were raised in liver enzymes, and the LDH was also high. Now, LDH is a surrogate marker for us. It just tells me that there is active erythropoiesis happening, and there's a lot of cell turnover happening. So there's destruction as well as production happening. So that's just a this thing. But the family history of a similar attack and the desaturation and splenomegaly. When I look at the smear, this is the smear. So this is sickle cell anemia. So yeah, and sickle cell anemia gives you these vaso-occlusive crises because the sickle cells go into your arterioles and they get stuck there and they lead to the painful crisis that is happening. Most of our sickle cell anemias in India at least respond beautifully well to hydroxyurea. So we don't actually want to transplant them unless they actually give us an indication. Either they've had a stroke or they're having a lot of painful crisis, they've had multiple hospital admissions. That's when we start thinking of, or if they have a matched sibling donor who's normal, then you want to prevent all this from happening and want to transplant them early. Otherwise, hydroxyurea works beautifully well for them. The dose is about 30 milligrams per kg per day.
But why did this child present so late at 15 years? One would have expected even earlier.
Yes, he should have presented earlier, ma'am. I just think that it was missed and he was just treated symptomatically at other places.
Okay.
But there is no way we can say that there is a certain age predilection happening. They can, as I said, our sickles are milder sickles. So there must have been the infection maybe actually precipitating the crisis as well.
Okay.
And you do the HPLC, it will show you that there is an HBS
more than
peak as well. Yeah, and that is there. A sickling test is done on a peripheral smear, and that is also positive. So our sickle cells present with hemolytic anemias. They usually have reticulocytosis. They can present with vaso-occlusive crisis. They can present with splenic sequestration. I have seen a priapism also happening, hand-foot syndromes, and a chest stenosis is what this child was actually happening. The next is a 12-year-old female, pallor for 3 months, fatigability for about a month, puffiness and edema of the feet for about 15 days. There's no history of bleeding, there's no history of weight loss, no history of jaundice, no history of prior blood transfusions. But what is striking is hyperpigmented knuckles. Now, again, hyperpigmented knuckles tell us that this could be a folate or a B12 deficiency, and this thing guides us that your MCV is higher in these patients. So anything more than 84, you're thinking of a B12 deficiency. Platelets are slightly low. So nutritional deficiencies may not just be anemias. You can have the other cell lines also getting affected in these patients. Macrocytosis. So unless you do a bone marrow, we call it a macrocytosis. It's only when we do a bone marrow do we say it's a megaloblastic anemia. So this is a macrocytic anemia. The tongue is generally red, and when you look at the peripheral smear, you can see that there are these hypersegmented neutrophils that are present. So that gives you your diagnosis as well. The bilirubin was low. Again, the neutrophils are much better observed in this. And the bone marrow is typical for a megaloblastic anemia. So that tells you that this thing is a B12 deficiency. Then there's a 20-month-old girl who presents with pallor. So young child, less than 2 years of age, pallor and fatigue. History of a viral illness preceding the anemia. No skeletal abnormalities, no hepatosplenomegaly, but the hemoglobin is 5.6. Again, it's a microstatic anemia, but she's also got a low white cell count. Her ANC is only 920, and the platelets are just borderline. It's 150,000. The reticulocyte count is also low. So you know that this is a decreased production. Peripheral smear is unremarkable. Then differential, because it's preceding a viral illness, with a history of a preceding viral illness, we think of transient erythroblastopenia of childhood, or TEC. But this is generally a reduced production happening, and this is kind of self-limiting. It generally will respond. Transfusions are only required in about 50 to 60% patients, and the children get well very quickly. However, if you have skeletal deformities present, then you think about either a Fanconi's or an inherited bone marrow failure syndrome, which could be anything like a Diamond-Blackfan or any other syndrome happening. So always examine the child very well when you're looking at any anemia present. And Fanconi's can present with different anomalies as well. So this is the classical Fanconi's that we see. If you were to do a bone marrow, we generally find that these are aplastic anemias that are present. Stop now. Any questions?
Lots. Lots. Can anyone else for questions? Yeah, please continue with this case. I think somebody's mic is on and there's a Dr. Sandeep Borse, can you please put your mic off? Dr. Sandeep Borse. Dr. Sandeep Borse.
Yeah, I'm telling him.
Please mute yourself, Dr. Sandeep. Can the host mute Dr. Sandeep or make me a co-host?
Sometimes we get young children who present to us with fever, rapid breathing, and you have a history of consanguinity in these patients. They've got a lot of chest signs, but they've also got hepatosplenomegaly present, and you get a lot of nucleated RBCs present. When we asked, we actually did just the chest X-ray for this, and this was giving us the diagnosis for in this patient. This is a case of osteopetrosis, where you can see that the bones are very, very prominent. It comes out, picks up. They can present with anemia as well because the bone marrow is getting involved in these patients. The only treatment for osteopetrosis is to do a bone marrow transplant in these patients. A lot of our anemias can also be leukemias, and they may present with bleeding episodes present. So you're thinking that this is acute blood loss, but when you look at the peripheral smear or you do a bone marrow in these patients, we actually pick up leukemias in these patients. This particular case is what we call an acute promyelocytic leukemia, where the presentation is very severe. Often they land up in the ICUs itself with a lot of bleeding from all spots. So skin, conjunctiva, melena, hematomesis as well. You have hepatosplenomegaly present, and when we do the bone marrow, we get these classical AML-shaped cells, but you also can see these rods that you see over here. These are called faggots or rods, and this is classical for APML. The reason I put it over here is most people think that ALLs or AMLs have a bad prognosis, especially AMLs, but APML has a very good prognosis. The presentation is very severe, but once we start treatment, they generally do very, very well. So we have their survivals in more than 80% as well. When we're thinking of autoimmune hemolytic anemia, then you get an acute episode happening, and that time the patient will present with high colored urine, with joint pains, with icterus, with mild splenomegaly present, with a high LDH and a high bilirubin. And as I said, we ask for a Coombs test, and the Coombs test tells us that this is immune mediated. And a DSDNA tells you that this is autoimmune. In this case, patient choose developing SLE as well. Now, when
why did you do a chest CT?
in this child, because she presented with a lot of one severe anemia and she had she was going into failure in our patient. So that is why this chest CT was
Chest
done
and
in this
abdomen.
patient, because yeah, we were worried that this is actually.
Your voice is there's something wrong with your sound, Ruchira. We are not able to hear you continuously.
Can you hear me now, ma'am?
Yeah.
My network is a little poor over here.
Okay.
So you look at the warm antibodies and you look at the cold antibodies in our patients. Usually the immune-mediated hemolysis is warm antibody-mediated, and generally the hemolysis is extravascular in these patients, whereas a cold antibody-mediated is post-infections, and this is an intravascular, could also be an extravascular hemolysis happening in these patients. And generally with cold AIHA, steroids generally don't really work with these patients. AIHA can affect different organs, so we worry about pneumonias in these patients. We worry about sepsis, acute renal failure. And if you have an autoimmune hemolytic anemia with thrombocytopenia, then it's Ivan syndrome, which can also be a predisposition to primary immunodeficiencies. So when you look at the peripheral smear, if you have thrombocytopenia present, then a further detailed workup actually needs to be done for these patients as well. However, not all patients have a hematological basis. So we had this 5-year-old who came to us with yellowish discoloration for the last 10 days, but a history of a similar episode about a year back, but that settles spontaneously in 2 weeks, doesn't have any history of fever or altered sensorium, has never been transfused, but there is again a history of neurological illness in the elder brother, which started at 8 years, and they just lost the brother as well. Wilson's disease, yes. So this was occasional spherocytes, platelets were low, but everything else pointed towards a Wilson's disease. So serum ceruloplasmin was high, the urinary copper excretion was also high, and we could see a KF ring. So this was Wilson's disease with anemia as a presentation. So if you treated the Wilson's, this would have gone away. Whenever you have a child with hepatosplenomegaly, you worry about whether this is an acute presentation or it's a chronic presentation. If it's an acute presentation, look at infections, look at bleeding, look at malaria or AIHA. But if this is a chronic history of hepatosplenomegaly, then I think of more of hematological causes or a myeloproliferative or some other chronic infections over there. Just take home messages. As I said, responsible for anemia for term babies prior to 6 months, and preterm babies generally we say about 4 months or before they double their birth weight. Generally, if it's detected between 3 to 6 months of age, it will be either a congenital disorder of either the structure or hemoglobin synthesis that is happening. A good history taking and a very good examination gives you very good clues. So you don't need to run the whole gamut of tests for these patients, but we can decide which ones we want to go for first. Always remember that doing the transfusions, doing the tests before the transfusion helps us. So you should think of your differentials before you actually set out to do the transfusions. And iron deficiency anemia generally does not need a transfusion in most cases. In children also, because the bioavailability of iron is pretty good, we generally avoid parenteral therapy also in our